Hi, everyone. My name is Megan Patel. Today, I'm going to be talking about novel therapy for COVID-19, as well as how to manage some of the adjunctive complications that you'll see from COVID. I am the current MICU pharmacist. I also take care of patients in the COVID ICU. This presentation is going to be focused on treating patients with active COVID disease. We just don't have the time to go over any of the vaccine data. And this is also going to be talking about management in adult patients. As I go through this presentation, if you have the handouts with you, several of the slides you may have in your handout, but I have not included verbally in this presentation just because of time. We don't have time to go over everything, but I have included more information in the handout as an FYI if you need it. Our objectives of this presentation are to apply current literature to guide medication decisions for the management of patients with COVID-19, discuss adjunctive treatment strategies to manage complications of COVID, and describe strategies pharmacists can implement to assist with nursing care for a COVID patient. Some of the medications that I'm going to talk about today are not FDA approved, but have been given emergency use authorization, and I have no financial disclosures. So we all know that this pandemic has been relatively devastating on not only the US population, but also healthcare resources, stretching nurses, providers, pharmacists to the brink of practice. It has also been putting a strain on our personal protective equipment or PPE, and has also been causing a significant burnout among providers as we see the devastation that this toll has on our patients without having a cure or the magic ability to fix the patients. What a lot of you may not know is that COVID has also put a strain on healthcare literature that we've also kind of referred to as a paperdemic. So a PubMed search on COVID has revealed that almost 90,000 papers have been published since March of 2020. That is a lot of literature to come out in such a short amount of time on a new disease state. And early on, this was very welcomed when we had no idea how COVID was spread, who was at most at risk for an infection or for symptoms, what treatment therapies were options, any information about the virus that we could get and use, we wanted to see it. But reviewing almost 90,000 papers would be more than a full-time job. Not even Dr. Anthony Fauci could review this amount of literature. And so how have we been able to apply this paper to our practice has just been overwhelming for a lot of clinicians to be able to sift through and read. This has also put a significant effect on paper quality. So we are looking for answers, and you may see case reports describing studies and describing therapy in 2 patients and 8 patients. And initially, this was exciting when you saw 8 patients may have had a benefit in therapy, but that's just not the kind of paper that you want to base therapy on when you're treating millions of patients. Patients have also been done poorly. Some of them had even been redacted by just poor quality and poor methods. This has also included a release of interim analysis, so papers that have been published without yet being finally completed. Release of papers on preprint servers, so papers that have been released to the internet without having been peer-reviewed or having been published in a journal, so they have not undergone the scientific rigor and scrutiny that other papers normally do. Information is also being released via press releases. So a company, for example, with Bamlinevimab, they put out a press release with a lot of data, and the FDA gave an emergency use authorization, but the actual scientific paper to follow was not released for several weeks later, leaving a lot of clinicians in this interim period where we weren't sure what data to use or how to interpret data that we just couldn't see. Finally, we all know that therapy changes over time. And so when comparing a medication to a standard of care, we have to remember what the standard of care is. So for example, in sepsis, we know that early goal-directed therapy was not heard of 20 years ago, but now it's an absolute standard of care. Giving early fluids is important for all patients. Even since March, therapy changes since COVID have been quite drastic. So early then, there was initial guidelines saying not to use steroids at all, to do early intubation to avoid it later, to use hydroxychloroquine and maybe azithromycin. And we know none of those things that we do now. We use steroids in everyone. We intubate patients only if they need it. Also, there's a significant amount of population homogeneity. There's not a lot of population homogeneity between the literature. So I want you to compare Chattanooga in April and May compared to New York in April and May. Even the differences between these two cities with COVID care is quite significant because they had a significant strain on their healthcare resources, their nursing resources. If you're comparing patients in one city to another, even patients who don't have COVID, if your doctors are caring for 60 patients at a time because you just don't have the amount of doctors to care for patients, of course, those patients are going to receive a lower quality of care than doctors who are staffed with who are charged of taking only care of 12 to 15 patients. And then finally, a lot of these papers are looking at clinical markers, are not looking at clinical markers, they're looking at surrogate outcomes. So that's looking at things like a viral load or the amount of virus that's present in the patient or the amount of antibodies that are present in the patient. That's what we call a surrogate outcome because we just don't know how that translates clinically to meaningful outcomes like days in the hospital, days of symptoms, mortality data, whether or not a patient requires intubation. We all have to balance the need for information and the want for information of therapy that's going to help these patients with our standard for scientific rigor and standard for medication therapy and how to base our decisions. So I've divided this presentation into two parts. The first part is going to talk about COVID therapy, therapy specifically related to treating COVID. And the second part is going to talk about adjunctive therapy and management of COVID complications. As I go through this presentation, I'm going to use the PICO format to talk about the different trials. If you haven't heard of it, this is patient population, intervention, comparison, and outcome. And I'll abbreviate it throughout the presentation as PICO. The first medication I'm going to talk about is dexamethasone. This is a glucocorticosteroid. The dose in COVID is 6 milligrams per day for 10 days, but there's alternative higher dosing in patients with acute respiratory distress syndrome of 20 milligrams per day for 5 days, and then 10 milligrams per day for 5 days. This was initially published in a trial last February in patients with ARDS without COVID and was found to have benefit. And I'll go over one of the trials here that did review this in COVID patients. We know dexamethasone can cause a significant amount of hyperglycemia, more so than other corticosteroids, and patients in the COVID units have especially seen problems with this. Dexamethasone has also the potential for increased risk of infection. It is an immunosuppressive agent. The main trial that's been published that has garnered support for dexamethasone is the recovery trial, and this is just a preliminary report. This is in patients who are hospitalized with suspected or confirmed COVID, and patients were randomized to either receive dexamethasone, 2,100 patients, versus usual care, 4,300 patients. The primary outcome is 28-day mortality, which I'll show you on the next slide. They also found that dexamethasone had a shorter duration of hospitalization compared to patients who received usual care, 12 versus 13 days. And they also had a lower rate of progression to mechanical ventilation. This is a graph from the trial to orient you. I'll talk about each of these boxes separately. So on the y-axis is mortality, and on the x-axis is days since randomization. The usual care group is in the black line, and dexamethasone is in the red line. So for the total patient population for all participants, dexamethasone had a statistically significant improvement in mortality compared to patients who received usual care. This was especially seen in patients who had invasive mechanical ventilation. You can see the overall mortality rate is much higher. We know that's true for intubated patients, and dexamethasone had a significant improvement. This was also seen in patients who were on oxygen. Dexamethasone had an improvement compared to usual care. This was not seen for patients who did not require oxygen therapy. And in fact, although not significant, dexamethasone may have had an adverse reaction and an adverse outcome effect on mortality, potentially causing more mortality than patients who received usual care. The CODEX trial was released that compared dexamethasone high dose in patients with COVID. So in COVID positive ICU patients with moderate to severe ARDS, patients were randomized to receive dexamethasone 20 milligrams per day for 5 days versus 10 milligrams per day for 5 days compared to usual care. I'm sorry, I meant to say 20 milligrams for 5 days, followed by 10 milligrams for 5 days versus usual care. And they did find an increased amount in ventilator-free days, so days where you were not required to be on mechanical ventilation in the dexamethasone group compared to the usual care group. A meta-analysis published by the REMAP-CAP group. This is a group of authors that have studied a lot of different domains of care for COVID. You'll hear me talk about the group in a publication later in this presentation. They did a meta-analysis. So to orient you to this, the dashed line in the middle of the graph here is the line of no difference. And they had looked at all different steroids in COVID, so dexamethasone, hydrocortisone, and methylprednisolone. And they found that all steroids were found to have a benefit in COVID compared to usual care. And that difference was especially seen in patients who received dexamethasone. So the Infectious Disease Society of America recommends dexamethasone if hospitalized patients with severe disease, which they've defined as being on supplemental oxygenation. And they do recommend dexamethasone. There are other steroids, but other steroids should be used if dexamethasone is not available. The National Institute of Health recommends dexamethasone in patients who require supplemental oxygen for a duration of 10 days or until hospital discharge. And the World Health Organization recommends dexamethasone in patients with severe disease, which they define as an oxygen sat of less than 90% on room air. So self-assessment question number 1, what outcomes has dexamethasone been shown to improve in patients with COVID? A, decreased mortality in all patients. B, decreased mortality in patients requiring oxygen. C, increased ventilator-free days in patients with ARDS. So it's going to be both B and D. So decreased mortality in patients requiring oxygen. We saw that in the recovery trial. And then in higher dosed steroids, we also saw an increased amount of ventilator-free days in patients with ARDS. So now on to remdesivir. This is the first medication to receive FDA approval specific for COVID. It was initially studied in patients with the Ebola virus, which is how it was kind of already developed, and they thought to apply it to COVID therapy. It works as an inhibitor of the COVID RNA polymerase, and its treatment course includes a loading dose of 200 milligrams on day 1, and then followed by 100 milligrams daily for either 4 days or 9 days, depending on if you want a total of 5-day or 10-day treatment course. Should we use it in patients with acute kidney injury? It has not been studied in patients with a creatinine clearance of less than 30. The initial emergency use authorization and the FDA approval does not outline its use in those patients. And the thought of the reason why these patients are excluded is that because remdesivir is formulated with cyclodextran as the excipient, we know that the other medication that uses cyclodextran, voriconazole, has some data of potential buildup of cyclodextran causing some hepatic and renal toxicity. Some expert opinions with remdesivir have stated that the amount of cyclodextrin in this medication may not be enough to actually cause harm in these patients. We know it is removed by dialysis, but here we are not using it in these patients because it's just not studied that way. And then finally, side effects of remdesivir include an increase in AST and ALT. About 7% of patients will see that. And then anecdotally, we've typically seen this on day 3 through 5 of therapy. We'll see a slight bump. So the main trial to support the benefit of remdesivir is the ACT-1 trial. This was done in patients hospitalized with COVID. 85% of patients were considered to have severe disease, which they considered to be an O2 sat of less than 94% on room air or tachypnea. And they were randomized to receive remdesivir for 10 days versus placebo. This is the World Health Organization clinical scale for COVID. I'm going to keep coming back to this because it's used in a lot of different literature to describe outcomes for patients with COVID. And it's kind of split into 4 different groups. So groups 1 and 2 on the clinical scale are patients who are not hospitalized and may have minor limitations on activities. Groups 3 and 4 are patients who are hospitalized but either no longer require ongoing care. Again, I'm not quite sure if you don't require ongoing care while you're hospitalized at that point, but group 4 is also patients hospitalized but not requiring supplemental oxygen. Groups 5, 6, and 7 are the patients that are hospitalized and requiring oxygenation if you're at group 5. Group 6 requiring non-invasive ventilation, being CPAP or BiPAP, or high-flow oxygen device, which here you'll hear referred to as vapotherm or high-flow nasal cannula. And then group 7 being intubated, and then a WHO scale of 8 is death. So in the Act 1 trial, their primary outcome was time to recovery, which they defined as a category 1, 2, or 3. So those are patients who are at home or either hospitalized but not requiring ongoing medical care. Maybe they're waiting for placement. And they found a difference with remdesivir improving time to recovery by about 5 days, 10 days in the remdesivir group versus 5 days in the placebo group. When they stratified this, however, according to subgroup analysis, to orient you to the graph, this dashed line here is the line of no difference, and remdesivir superior being on the right-hand side. They only found 2 groups that were found to have benefit. The first is if you had a symptom duration of less than 10 days, and also if you have a baseline ordinal score of the WHO scale of 5, which means you are receiving oxygen. They did not find benefit in patients who are not on supplemental oxygen. They did not find benefit in patients who are on high-flow nasal cannula, non-invasive ventilation, or required mechanical ventilation. They found that remdesivir did find a time to clinical improvement via the WHO ordinal scale. So a 1 category improvement was found to be shorter with remdesivir compared to placebo. A 2 category improvement was also found shorter with remdesivir. Remdesivir also reduced length of hospitalization, days of oxygen supplementation, but they found no difference in days of mechanical ventilation. The Solidarity trial was just published in this last December, and it was an interim analysis with a much larger patient population group compared to the Act 1 trial, which was 500 patients in each group. This had almost quadruple the amount of patients in each group, and they were randomized to receive remdesivir for 10 days or usual care. Their primary outcome is mortality, which I'll show you on the next slide. When looking at patients who are still hospitalized on day 7, they actually found a slight increase in patients who were receiving remdesivir, and they found no difference on whether the patients required initiation of ventilation or not. And their primary outcome of in-hospital mortality, which is on the y-axis, and days since randomization on the x-axis, they found no difference between groups. They also did a subgroup analysis based on age at entry and whether or not the patients were required mechanical ventilation, ventilatory support, and they found no specific subgroup that seemed to benefit from remdesivir. What they also published is a meta-analysis that looked at all the different trials that had reviewed remdesivir so far. So you can see the Solidarity trial, the Act 1 trial, some other small trials that were initially out of Wuhan, China, and they found that only 1 trial in 1 subgroup had a benefit to using remdesivir, and that was in the Act 1 trial in patients who had low flow oxygen. And no other trial, you can see all these other medians here and confidence intervals cross this line of no difference, did they find remdesivir was better than placebo. Even in these other trials, when they looked at patients with low flow oxygen, they found no benefit to remdesivir compared to the control group. So here we do remdesivir for 5 days. A lot of these trials looked at a total of 10 days of remdesivir therapy. So what's the difference? This trial specifically randomized patients to either a 5-day or a 10-day course in patients who were hospitalized with COVID. In patients who had a 5-day course of therapy, 86% of patients completed therapy. And in patients with a 10-day course, only 44% completed therapy. And there was no difference in clinical outcomes between groups after adjusting for baseline characteristics. So what do the guidelines say? The infectious disease guidelines say that in hospitalized patients with severe COVID, they recommend remdesivir over no antiviral treatment. They define severe COVID as patients requiring oxygenation. And they specifically say in patients on supplemental oxygen, but not mechanical ventilation, they recommend 5 days over 10 days of remdesivir therapy. However, in patients who are on mechanical ventilation, duration can be extended to 10 days. And then in patients in COVID without the need for oxygen, they suggest against the routine use of remdesivir. The National Institute of Health recommends remdesivir only for hospitalized patients who require supplemental oxygen, but do not require oxygen through a high-flow nasal cannula, non-invasive ventilation, or mechanical ventilation, because those were not subgroups that found a benefit in the Act 1 trial. The World Health Organization recommends against remdesivir, regardless of COVID severity, for anyone. And remember, the World Health Organization takes care of the entire global population. So not only resource-rich countries, but resource-poor countries as well, where an expensive remdesivir therapy, the benefit must really outweigh both the risks and the cost of the therapy for those types of patients. They reviewed the evidence and found that based on the 1 subgroup in our Act 1 trial, that the benefit just did not outweigh the potential benefit in that one trial was just not seen in any of the other trials, and remdesivir shouldn't be used. So self-assessment question number 2, based on current guideline recommendations and trials, which patients are most appropriate for remdesivir therapy? A, patients who are intubated, B, patients who require oxygenation, C, asymptomatic patients, or D, no one. So B, yes, patients who require oxygenation. This is what the Infectious Disease Society and the National Institute of Health guidelines recommend. But if you follow the World Health Organization guidelines and potentially consider the meta-analysis that shows overall a combination of all of these trials find no benefit to remdesivir, potentially the answer is D, no one should be receiving remdesivir therapy. So of course, here at Erlanger, we took remdesivir criteria back to P&T in December. Criteria for use includes symptom onset of less than or equal to 10 days, and that's based on that subgroup analysis in the Act 1 trial. Also requiring oxygen supplementation to keep the O2 stat of greater than 89%. And we require a creatinine clearance of greater than 30 unless the benefit outweighs the risk, and this is clearly documented by both the ordering team and nephrology. On to our next medication, baricitinib. This is FDA approved for rheumatoid arthritis, and it has been given an emergency use authorization for combination treatment with remdesivir for patients with COVID. It's a JAK kinase inhibitor or a JAK inhibitor, and it prevents some proteins that help assist with viral replication. It's given as a 4 milligram dose daily for 14 days as oral therapy or until hospital discharge, and it does require renal dose adjustment. It is an immunosuppressive treatment, so it's not recommended if patients have a co-infection, either bacterial or viral. And in some of the literature studying baricitinib in rheumatoid arthritis, it does increase thrombosis rates and hepatic transaminases, which of course remdesivir also does. In the Act 2 trial, as the one that primarily looked at baricitinib, they included patients with COVID who had one of the following: so radiographic infiltrates, requiring supplemental oxygen or having an O2 sat of less than 94% on room air, and patients who were on steroids were excluded from the trial. Patients were randomized to a combination of baricitinib plus remdesivir versus placebo plus remdesivir alone, and this was a 10-day course of remdesivir. Their primary outcome was a time to recovery within 29 days, and this is defined the same as the Act 1 trial, so a 1, 2, or 3 on that WHO scale, which is patients who are at home, not hospitalized, or hospitalized without ongoing need. This was found to be different between the groups, barely statistically significant. 7 days in the combination group of time to recovery versus 8 days in the remdesivir alone group. For their clinical status on day 15, the combination group of baricitinib plus remdesivir were more likely to have a better clinical status, but there was no difference in duration of oxygen requirements or mechanical ventilation. When they did a subgroup analysis, similar to the Act 1 trial, they found that the duration of symptom onset did not seem to differ in whether or not baricitinib was beneficial, nor did disease severity. But when they divided subgroups according to that World Health Organization clinical scale, only one subgroup was found to have a benefit, and that's group 6, which is patients who are hospitalized on non-invasive ventilation or high-flow oxygen devices. So this is patients on Vapotherm, BiPAP, CPAP, high-flow nasal cannula. And again, that's different than the patients that we found benefit to remdesivir alone. So concomitant steroids were not allowed to be used in this trial unless they had another indication, such as ARDS, asthma, septic shock. And 223 patients of the 1,000 patients total ended up requiring steroids. Patients who received steroids and baricitinib had higher rates of infection compared to those who didn't, 25% versus 5%, which is pretty significant. And they found no difference in any clinical outcomes if you had the combination of steroids plus the baricitinib remdesivir therapy. The National Institute of Health recommends against baricitinib recommends against it outside a clinical trial unless steroids cannot be used. IDSA says that among hospitalized patients with severe COVID who cannot receive steroids because of a contraindication, they do suggest baricitinib with remdesivir rather than remdesivir alone. But however, the combination of baricitinib, remdesivir, and a corticosteroid should only be done in the context of a clinical trial. The World Health Organization has not yet commented on this, but given their stance on remdesivir and the fact that this has to be combined with remdesivir for use, I can only imagine that they're not in support of the therapy. But again, that is just my best educated guess. So at Erlanger, we took this to P&T and recommended it not be approved for use for COVID here. And this was for the following reasons. So it has not been studied with steroids, and it has an increased rate of infection with steroids. And remember from the recovery trial with dexamethasone that steroids have been actually shown to decrease mortality in patients with COVID versus baricitinib, which has been shown to improve time to recovery by approximately 1 day. The data for dexamethasone is just so much more robust. Also, only one subgroup of patients in this trial had a benefit, and that's on patients with high flow nasal cannula or vapotherm. And then again, minimal benefit is seen, 1 day faster recovery. Next, we'll move on to Bamlinevimab. This has been given an FDA emergency use authorization for COVID. It works as a neutralizing monoclonal antibody that helps target receptor binding, so it may block entry of the virus into the host cell. It's given as a 1 hour infusion of 700 milligrams and then requires a 1 hour observation period afterward. The FDA emergency use authorization criteria is very specific. It is for outpatient therapy use only, patients who are greater than 12, weigh at least 40 kilos, and are considered high risk of progressing to severe disease. And they specifically define that as one of the following. Patients must be obese, have diabetes, chronic kidney disease, an immunosuppressive disease or treatment, or be 65 years or older, or be greater than 55 plus have one of the following: cardiovascular disease, hypertension, COPD, or respiratory disease. The trial that garnished this FDA designation for the Bamlinevimab is the BLAZE-1 trial. This is an interim analysis. This studied patients who were COVID positive and had a positive test within the previous 3 days and had at least one symptom of COVID but were not yet hospitalized. This is actually a phase 2 trial. This was a dose-finding study. So they randomized patients to receive Bamlinevimab 700 milligrams, 2,800 milligrams, or 7,000 milligrams. And that was split into 3 different groups and for a total of 300 patients versus placebo, which is 143 patients. Their primary and major secondary outcomes were viral load amount. But in one of their secondary outcomes, they reported number of hospitalizations at day 29, and they found that Bamlinevimab had only 5 hospitalizations in their group versus 9 hospitalizations in the placebo group. I point out the specific ends here because it's much less impressive than 6.3% versus 1.6%. Remember, this population trial is pretty small. So we have to take into account the trial design. Remember, this is a phase 2 trial. There are hardly any other medications that would ever have a phase 2 trial published, let alone FDA giving immediate approval for use, or not quite FDA approval, but FDA consideration for use and release for use to the US population. The number needed to treat, if you believe this interim analysis, the number needed to treat, however, is 21. So every 21 patients you treat, you could potentially prevent 1 hospitalization by day 29. That's not quite that impressive. However, if you live in a county, for example, let's take Los Angeles, where the hospitals are just overrun with COVID. They're saying nurses are working a 1-to-4 ratio instead of a 1-to-2 ratio here. If you give this to 100 people, could you potentially prevent 4 to 5 hospitalizations and save some of those healthcare resources? Maybe. Not quite sure based on this trial, but that's kind of the thought process of why so many people were so excited about this medication. One of the things to consider with Bamlinevimab is the logistics of an infusion center, including staffing. So although it sounds great to prevent 4 to 5 hospitalizations, giving this to 100 people is 200 hours of not only infusion time and follow-up time for observation. If the hospitals are so overrun, who are you going to get to administer the medication and observe those patients? I know here that was one of our major barriers to implementation because our only designated infusion center sees oncology patients, and that's not kind of the patient you want to have next to your chemotherapy patient as a COVID patient actively receiving this medication. I know Memorial has a specific infusion center, and so do some hospitals in Memphis. So if you have COVID, you're found to qualify for this medication, you call, you make an appointment, you go the next day and you get this medication. But here we just don't have the logistics to be able to set something like that up. And the benefit that we found is kind of minimal. So at Erlanger, we've approved this for use by our P&T to be given in the emergency room if patients are tested positive for COVID and found to meet the criteria. and it's only approved while the government is funding the medication. So the government is paying for this under Operation Warp Speed, but once we have to start paying the medication ourselves, we're going to take the evidence back to P&T and redetermine if we need to continue using this medication or not. So the IDSA guidelines suggest against the routine use of Bamlinevimab based on the very low amount of evidence. The National Institute of Health guidelines say that there's insufficient data to recommend either for or against. However, either Bamlinevimab or the other monoclonal antibodies should not be considered standard of care. And the World Health Organization has not commented at this time. The second group of monoclonal antibodies to be given as outpatient therapy is Kessarivamab and Nivab. They have received emergency use authorization for those of you who called into P&T this morning. So they received this EUA designation in December, but the trial was not published until last week. Initially for Bamlinevimab, they got an EUA approval for use based on this trial that was released via a press release by the manufacturing company, and the actual trial was not released for several weeks later. So this leaves a lot of clinicians kind of in this interim period where you're given this medication by the FDA to say, okay, you can go ahead and use it, but without any data to make your own informed decision on if it's appropriate or not. So this combination therapy works similar to Bamlinevimab, blocking the binding of this the SARS-CoV into the host cell. It's 1,200 milligrams of each of the medication to be given over a 1 hour infusion. And the criteria is the exact same as Bamlinevimab. So symptomatic from COVID, but not yet requiring hospitalization or oxygen therapy, and you're at high risk of progressing to severe disease. So our self-assessment question, what are the restriction criteria for receiving Bamlinevimab after a confirmed COVID test per the FDA EUA? A, asymptomatic outpatient only. B, symptomatic inpatient admission. C, symptomatic outpatient only in age less than 55, or D, symptomatic outpatient only and high risk of disease progression. So D, yes, exactly. I didn't really want to talk about this medication, but boy, are a lot of people talking about it. So I thought it would be pertinent to include so that you're all aware of the evidence for ivermectin. So we know that this is an anti-helminth used for hookworm and other worm diseases. Here, if you ever see it used prior to all this, it's probably used for patients with scabies. So why are we suddenly talking about this? There was an article, a retrospective article that was published in Chest. It was originally released in October, but it was just released in an issue in January, so a lot more people are seeing it. Comparing a 200 mic per kilo dose of ivermectin compared to usual care in a very small amount of patients. It was a retrospective article, so physicians were allowed to determine who received ivermectin and who didn't, and that allows for a lot of selection bias based on who potentially could benefit from disease or not. They were not randomized. 90% of these patients also received concomitant hydroxychloroquine and azithromycin, which kind of tells you the state of COVID therapy at the time that this trial was performed. More patients in the ivermectin group received a steroid than patients in the placebo group, but only 39% of patients in the ivermectin group received a concomitant corticosteroid, and we know that that significantly improves mortality. One of the only outcomes that they found beneficial was in the matched cohort, so matching based on baseline characteristics. There was less mortality in the ivermectin group in patients with severe disease. So only 47 patients total out of the near 300 patients in this trial were considered to have severe disease. And they found that the patients who received ivermectin had a 32% mortality versus patients who did not had an 81% mortality. Wow, is that a difference? 50% mortality reduction from ivermectin in a group of 47 patients. It's almost too good to be true, right? Almost too good to be true. So there's a lot of critique about this trial because really a 50% mortality reduction is just something you don't see in the literature. There's got to be something else about these patients that may not be balanced between groups. Again, it's retrospective and a small amount of patients. But these numbers, if you don't really read the trial and you read the abstract, that looks really impressive. And maybe I should give it to all my patients. The National Institute of Health is the only organization that's published a comment on ivermectin, and they say there's neither data for or against for use at this time. So this is the data to be aware of in case you see prescribing of ivermectin. I know we've had some physicians who've already used it, and some people have been telling me that it's outpatient therapy. People are prescribing this. It's not recommended at this time. And then finally, to briefly talk about convalescent plasma. So this is a blood product that contains antibodies from patients who have recovered from COVID-19, and you give it as an infusion to someone who has an active disease, thinking that me, the person who's recovered, if I give you the antibodies to fight it, you, the active infection, could potentially have more antibodies to fight the infection. So the risks are very similar to any blood product with transfusion-related reactions. Several new trials have come out. They found no difference in efficacy outcomes. I've included one of them in your handout. So initially, this is something we were doing on a lot of patients. We were enrolled in a trial, a national trial here to do it. We haven't really done it in the last month or two because it's just not been shown to be a benefit. Are there any other therapies that have been used for COVID? Well, of course, we're trying everything. Hydroxychloroquine, as you know, was initially used, has not garnered a lot of support. All of the guidelines recommend not using at this time. Melatonin, vitamins, PO-N-acetylcysteine, fluvoxamine. The latest thing I've seen on Twitter, people talking about is colchicine therapy. It's great that we're trying to find so many different cures for COVID. We know it's a very devastating disease, but sometimes I think, as I mentioned before, some of these papers come out that are poorly designed with very few amount of patients with this very surprising, exciting data that just doesn't pan out when we expand it to a larger amount of patients. And so I want to caution you in any of this to wait until more evidence is released. I know a lot of our hospitalists are prescribing vitamins unless they're prescribing them, 15 times a day. I can't really see that harming the patient, but there's not a lot of evidence showing that vitamins are the answer. So part 2, adjunctive treatment, we're going to talk about some of the other complications of COVID, the first being oxygenation. So we oxygenate patients the same as if they developed acute respiratory distress any other way. This includes low tidal volume ventilation, prone positioning, which means placing the patient on their stomach to help with alveolar recruitment, and then finally deep sedation and paralysis to help with ventilator dysynchrony and achieving this low tidal volume ventilation. Finally, we use inhaled epoprostenol for refractory hypoxemia. The National Institute of Health says that you may try this for rescue therapy. However, if you don't see rapid improvement, then therapy should be discontinued. So it'll either work or it won't. And if it doesn't work, you should just discontinue therapy instead of wasting healthcare resources by continuing to give this medication. I know we're using a lot of it here, and a lot of our providers does say it helps either prevent intubations or helps patients improve. For anticoagulation, so patients with COVID are seeing higher rates of pulmonary embolism, and this is occurring in the absence of DVTs, and it's occurring in some of our peripheral pulmonary arteries. So that's different than the traditional PE from a DVT that we think about. Should we use D-dimer to stratify patients into risk of whether they're going to develop a PE or not? The National Institute of Health says that there's no evidence for doing this either for or against. I know some of our providers here are doing it. If they have a high D-dimer, they're quick to put them on full dose, kind of preventative anticoagulation. And again, the evidence just doesn't really say one way or the other if that's something we should be doing. One thing I have seen some providers do here is use extended VTE prophylaxis for after discharge, and that is not recommended by the guidelines. So National Institute of Health and the World Health Organization say to do DVT prophylaxis according to your usual standard of care. So if you would have given it to that patient anyway, had they not have COVID, go ahead and give it. If you weren't going to, then you shouldn't. The International Society for Thrombosis and Hemostasis says that all hospitalized patients with COVID should receive a low molecular weight heparin unless they have severe renal impairment or have an increased risk of bleeding. And the Anticoagulation Forum supports increased doses of VTE prophylaxis, and they include this to mean Lovenox 40 twice a day, 0.5 milligram per kilo of Lovenox twice a day, 7,500 TID of heparin, or even a low-dose heparin drip. I know I've seen all of these strategies at some point or another in our given patients, depending on the provider that's on service, some of their coagulation markers like their D-dimer, as well as some of the other patient risk factors that we have to take into account. So if they have active cancer and they're at increased risk of VTEs already, maybe that is someone that you want to put on a higher dose or more preventative medication for anticoagulation. I know a recent study that was just published looked at the rates of VTE incidence in the critically ill patient and found a very good outcome of doing prophylactic therapeutic DVT treatment in those patients compared to patients with usual care. I want to point out it's not just DVTs and PEs that we're seeing increased rates of, it's also arterial thrombosis. So MIs and strokes we're also seeing an increased incidence of in these patients. There's also a concomitant inflammatory syndrome associated with COVID. So this can either been referenced in the literature as hemophagocytic lymphohistiocytosis or HLH, or also more commonly cytokine release syndrome. We've seen cytokine release syndrome after several chemotherapy agents, and that's kind of when this has first been described. But it's basically a release of inflammatory markers such as D-dimer, ferritin, lactate dehydrogenase, or C-reactive protein that causes an overwhelming inflammatory state and is associated with poor outcomes in these patients. So there have been a lot of different anti-inflammatory or interleukin medications that have been studied for this cytokine release syndrome in COVID. Tocilizumab is the one that has been most commonly described, but IL-1 inhibitors as well as IVIG have also been studied. So tocilizumab is an IL-6 inhibitor, which is one of the main cytokines that's thought to be responsible for this inflammatory cascade as well as tissue fibrosis. The dose is typically 8 milligrams per kilo with a maximum dose of 800 milligrams. Side effects of tocilizumab include hepatic injury, and it is an immunosuppressive agent, so potentially an increased rate of infections. There are a lot of negative prospective trials on tocilizumab. I've listed the most recent ones here in the handout that I've emailed you. I've gone through some of these more in depth, but I just don't have time to go over all of these in detail today. What I am going to go over is some of the more recent trials that have published that have potentially shown benefit, because I think we're going to start seeing more tocilizumab soon. I know we saw it initially when COVID first happened. We weren't quite sure who to use it in or when to use it, but some providers were administering this kind of as a last line effort. And we haven't really seen it in a while, but I know at least Dr. Sethi with Pulmonary Critical Care is very excited about some of the newest trials that have been published, and I think we're going to see a push for this soon. So this trial was published in New England Journal just a few weeks ago. It's called the Impacta Trial. This included all adult patients who were hospitalized with COVID and had an oxygen saturation on room air of less than 94%, but were not on mechanical ventilation or non-invasive ventilation. So this is your typical floor patient requiring oxygen. Patients were excluded if they had an active bacterial infection. 80% of the patients in this trial were receiving concomitant steroids, and about 80% were receiving remdesivir, so the care that we typically see of our patients today. They were randomized to either receive tocilizumab, 8 milligrams per kilo with a max of 800, or placebo. Their primary outcome was a composite outcome, meaning a combined outcome of either time to mechanical ventilation or time to death by day 28. When they did their Kaplan-Meier assessment, they found a statistical benefit in patients who had received tocilizumab compared to placebo. However, when you look at the raw numbers of this trial, there was no statistical benefit to receiving tocilizumab to comparing placebo therapy. So when you took out the time to event portion and whether or not the patients were just had mechanical ventilation or death, statistically, there was no difference between groups. They also found no difference in mortality by day 28, time to hospital discharge, time to a 2-category improvement on that WHO clinical scale, and adverse effects, including infection rate. So initially, the results of this trial seemed exciting. Worrisome for us from a cost perspective because it's in all patients with COVID. But when looking at the raw numbers, it had not reached the statistical significance. This is the trial that's been widely talked about that has not yet even been peer-reviewed, but has been published on a preprint server. It's by that REMAP CAP group, so I do expect it to be peer-reviewed and published. I'm not quite sure what journal they're aiming for. It was performed in all adult ICU patients with COVID. So there was no cytokine threshold. They did not have to experience a cytokine release syndrome to be given tocilizumab. And you can see the breakdown of the patients here. So 30% on a high flow nasal cannula, 40% on non-invasive ventilation, and 30% requiring intubation. Their median PaO2 to FiO2 ratio was 115, which means they had pretty significant ARDS, and 20% of patients required vasopressor support, so our typical COVID in the ICU type of patient. And the majority of these patients also received steroids, which is important because that's the workhorse and the backbone of most of our COVID therapy. So they were either randomized to open label tocilizumab at the standard dosing versus a control. They also had a small group who received a different IL-6 inhibitor, Kessarivamab, which I'm not going to talk about because we're not going to carry that medication. And it was a much smaller group. One thing to also point out in this trial, there are some other arms of this trial, including IVIG and IL-1 inhibitors. So each study site was able to choose which anti-inflammatory, anti-cytokine medication the patients were giving versus placebo. And then they combined all the different sites. So in their primary outcome was a composite outcome of either days free from respiratory or cardiovascular support up to day 21. And they found a significant difference. So 10 days free of support in the tocilizumab group at 21 days versus 0 days in the control group. And hospital mortality was also found to be significant, 28% in tocilizumab versus 35.8% in the control group. They also found time improved to ICU discharge, hospital discharge, and the World Health Organization scale at day 14. So a pretty positive, exciting trial that has not yet been peer-reviewed, has not been published anywhere. So at P&T this morning, we said that we are not going to use tocilizumab at this hospital for COVID, and that's been approved at this time, but we are going to revisit therapy once this trial is published, and we can kind of see what other hospitals are doing and whether the published data is the same as this preprint data. Right now, the IDSA guidelines recommend against routine use, and the National Institute of Health recommends against use outside of a clinical trial, and the World Health Organization has no comment on tocilizumab. I also want to talk about the rate of co-infection and whether or not patients with COVID are susceptible to bacterial infections. So a meta-analysis of over 30 different studies found an overall rate of a 7% bacterial co-infection with a higher rate in the ICU. However, if you've taken care of COVID patients here at Erlanger, you'll know that our antibiotic use is so much higher than 7%. I think a lot of this stems from just provider uncertainty. Your patient's admitted with COVID, now suddenly they're getting worse. We're just not sure, is that COVID that's worsening their respiratory status that's causing their transfer to the ICU, or maybe they developed a bacterial co-infection while they were here and the provider would just be remiss if they don't treat it. Of course, appropriate de-escalation and getting cultures is always preferred, and antibiotic use should be guarded as much as possible. There's also been some reports of fungal co-infection, specifically Aspergillus. So a lot of you will see voriconazole being prescribed as kind of last-ditch effort in some of our ICU patients where they're just not getting better. So could Aspergillus be on the differential for why their respiratory status is so poor? Some studies are reporting incidences of 5 to 8%. And despite the amount of antifungals we've used here, we have not yet seen a case of Aspergillus, to my knowledge, in a patient with, and Kyle's agreeing with me, in a patient with COVID here. So what can the pharmacist do to help the nurses with COVID management? So we have been using extended tubing outside of the patient's rooms for their IV pumps. You can see in this picture here all of the IV pumps and the CRT machines outside of the patient doors. And that's to help the nurses from using PPE to enter the room every time they have to titrate a sedative or a vasopressor medication. We've also been cluster timing medications to reduce the use of PPE for the nurse. So instead of an oral med due at 6, 7, 9, and 10, we've clustered them all to be due at 8. So the nurse just has to enter the room one time. And one other major component of this is mitigating drug shortages. So as COVID gets worse and more patients are in the ICU, more patients are needing ICU medications, including sedatives, paralytics, inhaled epoprostenol, and how we're managing this has become a large part of pharmacist therapy. Pharmacist actions. So where can you get more information? This presentation is current as of 1 o'clock today, but tomorrow 5 more trials are going to be published that may or may not refute exactly what I've just told you. So the ASHP has a really great COVID evidence table. If you follow this link, you'll get to a table of contents here, and where you can click on any of the medications such as ivermectin or colchicine right here. And so if a provider asks you about it, you can click on the medication, see all the trials it'll tell you when it was last updated, what the trials have shown, and give a little bit of perspective on if there's any guideline evidence. And then here are the links to the National Institute of Health guidelines, the IDSA guidelines, and the World Health Organization guidelines, which are all updated intermittently every month or so with different recommendations as trials are published with what clinicians should be using for therapy. And great question, Brittany. You do not have to be an ASHME member to access that table. Anyone can access it at any time, which is a really great resource. It is a 200-page document because, as you can see on this, I mean, they've reviewed a lot of different medications, but it is really great if you just need information on one specific thing that someone's asking you about. So in summary, should we use dexamethasone? Yes, there are some trials enough that support its use, improvement in mortality in patients who are requiring oxygen as inpatient therapy. So all these Medrol dose packs and dexamethasone outpatient therapy still isn't warranted. I know it's being done. And potentially using higher doses in patients with ARDS. That higher dose was initially studied and published last year in non-COVID ARDS patients with some pretty significant, exciting outcomes. And I know here we've adopted that to a lot of our COVID patients as well. Should we use remdesivir? Well, it kind of depends on what guidelines you follow. IDSA recommends it over no therapy. WHO recommends it to no one. So the best evidence is in patients with short duration of symptom onset, so starting within a symptom onset of 10 days or less, and patients on low flow oxygenation. Baricitinib, there's been minimal benefit so far. We're not yet using it here, and it's only guideline supported in patients who have a contraindication to corticosteroids. Bamlinevimab, outpatient only, minimal benefit again seen in a phase 2 dose finding study in one secondary outcome. So I just don't think the data is there to really support widespread use yet. Kessarivamab and Nivab, outpatient only. The trial was just published a week or so ago with kind of similar outcomes to Bamlinevimab. And Tocilizumab, nothing yet, but we'll likely see more use soon if we adopt some of the evidence from that REMAP-CAP trial. And then finally, hydroxychloroquine and ivermectin. No, not yet, not until there's more robust data showing its benefit. And this is the Erlanger code to register for your CE. And if I'll take any questions anyone has.
Great presentation.
Thank you.
Excellent summary of the data. I just had a logistical question about whether or not we used any Bamlinevimab in RED, and if so, is that being carried and dispensed by the main pharmacy?
Yeah, so Brittany was asking if we have actually dispensed any Bamlinevimab in RED. When I did kind of a brief review of dispenses since January, and we've probably had 15 to 20, I would think. So we are seeing it somewhat. I know the last weekend I worked, we had some issues with a physician potentially stretching some of the risk criteria for patients to meet criteria. But we have been seeing some of it. I know not nearly as much as Memorial because they have a more kind of streamlined outpatient process. I know there have been several physicians here that as they see their patients as outpatient, they've been referring them to the ER to get therapy. And we are not using the Kessarivamab or Nivab. We took that to P&T this morning, and we've denied its use because we just don't have the logistics to barely do the infusion of one, let alone figure out how to do the infusion of both of them. Any other questions or COVID comments? Yes. That's a great, so Neha was asking a question about a specific filter to use with dialysis machines to remove some cytokines in patients with COVID. And I had actually not heard of that. So I'm not sure what the evidence is on that or not, or if we even have those filters or how much they cost or, but I'm not sure. Anything else? Thank you all for your attention. I know COVID's kind of put a strain on all of us, so thanks for your continued hard work, and I hope you enjoyed the lunch. And let me know if you have any other questions, and I can send out the links to those ASHP tables and guidelines separately so you don't have to look through the PowerPoint, and anyone can use those to reference if you get physician questions while verifying orders. Thanks, everyone.